Okay, I think we're going to go ahead and get started now. I wanted to welcome everyone. We have, I think, more than 100 people now on today's webinar. And I'm Mary Shomon, a patient advocate and author and general thyroid patient. And I'm here to be, we have actually more than 150, I just found out. So we are going to be talking today about Are You Getting the Thyroid Runaround? And this is a webinar that's sponsored by the National Academy of Hypothyroidism, an organization that was founded by Kent Holtorf with the purpose of helping to educate practitioners and patients regarding optimal care of hypothyroidism. So today's webinar is going to focus on the thyroid runaround. What is it? The science behind the issues that are causing people to struggle with this runaround, and some of the things that you can do to really end run the process and get towards really good care with great practitioners. And so today's featured speaker is the founder of the National Academy of Hypothyroidism and the founder of the Holtorf Medical Group, Kent Holtorf, MD, who is an integrative physician with expertise in a variety of issues, hormone management, all sorts of integrative health care, fibromyalgia, chronic fatigue, and hormone balance. And so he's going to be talking us through a lot of the science and issues behind thyroid concerns. And so I wanted to go ahead and start off with introducing Kent Holtorf. And if you're following along with the online program, we do have a slides and PowerPoint presentation that talks about some of the specific issues and includes the references. So if you want to go and read some of the papers and things that Dr. Holtorf is going to be referring to, the references will be in the visual presentation. So thanks for joining us, and I'm going to turn it over to Kent Holtorf now.
Great. Thanks so much, Mary. And I'm really happy to be on tonight because it is so common. So many patients come in and they say, I'm tired, I'm fatigued, I have chronic fatigue syndrome, or depressed, or can't lose weight, and they go from doctor to doctor just saying, just exercise more, eat less, or here's an antidepressant, when all along it's their thyroid. And so it's such a big question. People are saying, how come I keep getting this runaround? They come to our office, we look at, black and white on paper, here you're low thyroid, they take thyroid the treatment, and oh my gosh, it can be life-changing. And then why doesn't my doctor know this? And it's kind of a complex question. One thing I found here, after doing this for about 10 years, I'm kind of used to it, but we have a patient, for instance, comes in 10 years of feeling horrible, give them thyroid, just feels so much better. They go back to their doctor. I thought the doctor would be happy and call, hey, what are you guys doing over there? 9 times out of 10, they're mad. They don't care to know. They just say, don't tell me what I was doing is wrong. And study after study, there's hundreds of studies showing that the way we're diagnosing and treating thyroid in this country is wrong. It's missing so many people. And when you look at, and the studies are there, and so why don't doctors look at these studies? Why aren't they treating it differently? And it's interesting. And, I'll talk to doctors and say, look, here's all the data. Oh, yeah, no, I can't do that. I only have 5 minutes with patients or 10 minutes with patients. I can't, I do the TSH. Well, you're showing it's wrong. Well, that's all I can do. It's really interesting. It's frustrating, interesting that that's the mindset. Basically telling a doctor what they've been doing is wrong. They just don't want to hear it. In fact, one study, a couple studies in New England Journal of Medicine and in internal medicine clinics showed that it takes on average a proven new concept. It takes on average 17 years to get accepted into mainstream medicine. They looked at why is that? Well, they found one. Doctors don't read medical journals. They don't. They just, they'll say they do, but they go to the conference in Hawaii or Vail and they do a little skiing and listen to a couple lectures. But they found even more important was the fact that if you give a doctor a number of studies that isn't what they were doing, they don't want to hear it. And that's what they found was really slows the progression of medicine, and that's what we find. So for those of you online, you see here's a cartoon I think really hits home, and it's a person with low thyroid is basically crushing them. So it sounds like you're just a little depressed. And that's what we see. And that person will get antidepressants and not address the thyroid. So Mary talked about our backgrounds here. So we'll talk about, what is the thyroid runaround, and I'll try not to get too technical, but I really want you to understand why, these standard tests aren't reliable, why the way we're diagnosing and treating thyroid in this country isn't reliable. So after you're done, you'll know more than your endocrinologist and your and your family practice or internal medicine doctor. So we'll go through a little basics here. Again, I don't want to get too technical, but so the hypothalamus secretes thyroid-releasing hormone. That then tells the pituitary, which is in the brain, to secrete thyroid-stimulating hormone, which then tells the thyroid to secrete T4. T4 doesn't do anything. Okay, it's inactive. Now, you hope it converts to T3 when it goes into the cell, but it can also go to reverse T3, which actually blocks the thyroid. Now, what we're taught in medical school, and 90+% of doctors do, is they say thyroid's very easy. When the thyroid levels drop, the pituitary should sense that and increase TSH. Okay, so if your TSH is high, your thyroid's low. If you get more thyroid, your TSH is low, and if it's normal, then you have normal amount of thyroid. Okay, very simple, right? Why do you need 4 years of study to learn that? And that's what most of them go by. But that would be great if it was true. It is true if you're totally healthy, no stress, no dieting, no inflammation, no obesity, no chronic inflammation. Again, if you're totally healthy, that may hold. But once you have these illnesses and conditions, basically they cause a suppression of the TSH, and it is no longer reliable. So, again, what are required steps for basically the thyroid to have activity? Well, you have to have proper hypothalamic pituitary function in the brain, which then makes the TSH. Then you need thyroid function, basically secretion of T4. Then you need to convert to T3. Then it needs to go into the cell. Again, it doesn't have any effect in the blood. It has to go inside the cell, into the nucleus of the cell, where it has an effect. Then you need receptor binding in that. So when you look at with all these things that can go wrong, actually they're all very common. Actually, the least common is the thyroid function problem, where the thyroid's not working very well. But that's the only thing that's checked with the TSH. Any of these other problems, which are very common, it doesn't detect them. So that's the whole problem, is the TSH will only detect primary hypothyroidism. So if there's a problem with the thyroid. But if there's any problem along this chain, it doesn't work. And they're actually very common, more common than the thyroid problem itself. So the standard way we talked about is to diagnose low thyroid based on the TSH above 4 or 5.7. There's controversy what that number should be, but it's crazy. You're arguing over what the number should be for the wrong test, because it will miss over 80% of people with low thyroid, especially if you're stressed, again, dieting, have a weight issue, chronic inflammation, chronic infection, chronic fatigue syndrome, so many problems, the TSH is no longer reliable. So, again, but that's what most people will go by. So what studies? And, again, these studies are out there, hundreds and hundreds. And if you go to all these references, when we look at the numbers there, are in the National Academy of Hypothyroidism. You see the bottom, diagnosis of hypothyroidism. That's where you can find those numbers, or the references. So they're all included there. So physiologic stress, there's 32 references there that show if you're stressed, TSH is not reliable. Depression, so many studies on that. Insulin resistance and diabetes, just getting older. If you look at the TSH drops as we get older, it doesn't mean that your thyroid's getting better. It's getting worse. Your TSH is dropping as well. And this will also be posted on the website this week. PMS, we'll look at a couple of studies that PMS show that 80% of people with PMS have low thyroid, but the standard tests don't detect it. Dieting lowers chronic fatigue syndrome, fibromyalgia. We'll look at a couple of studies on that. Obesity. And the problem is when you diet, the body tries to lose basically lower metabolism to gain that weight back by lowering the thyroid, by increasing reverse T3, which blocks the thyroid, lowering T3. So, and the thing is, too, it doesn't go back to normal even after normal eating. So unless you fix the thyroid when you're trying to lose weight, long-term success is going to be very, very difficult, because you just have to keep eating less and less because your metabolism is dropping from the low thyroid. So again, all those conditions are shown to have secondary and tertiary hypothyroidism. What's that mean? The pituitary problem, okay, causing that. Also, they have a transport problem. We'll go through those studies, and so the thyroid doesn't get into the cells. Let's see. And also thyroid resistance. The thyroid just doesn't do what it's supposed to. Again, not detected by the TSH. So here's a study here. looking at the fibromyalgia. So Journal of Rheumatology, major medical journal, looked at the incidence of fibromyalgia, the incidence of low thyroid in fibromyalgia patients. Now, they didn't look at the TSH. Well, they did, but they said, okay, let's do a more accurate test. It's called TRH testing, where you basically inject thyroid-releasing hormone and look at the response. It is the gold standard for thyroid assessment of thyroid. And they found that all those patients, all fibromyalgia patients were low, and the standard thyroid function test basically didn't. They looked in the normal range. In fact, the TSH averaged 0.86, which is lower than 1.42, which is average in normal. So people say, oh, they're a little hyperthyroid. But it's the exact opposite. Okay, they were low thyroid based on the gold standard test. Now, the TRH test, why doesn't people do that? They stopped making it. They said it wasn't necessary. So when you have a test that basically you have a test that was inaccurate, it didn't correlate with the gold standard, so what did they do? They eliminated the gold standard and said, oh, you don't need that anymore. It's crazy. New England Journal of Medicine, okay, major medical journal. They looked at the incidence of hypothyroidism in people with PMS. Again, they used the thyroid-releasing hormone test, the gold standard. They found 94% of patients with PMS had thyroid dysfunction, but with 0% of asymptomatic patients. So correlated perfectly with people with PMS. And so 65% of those tests were normal, would not have been detected unless they went and did further testing. Another study here, Journal of Psychiatry. They found basically, again, PMS patients, 70% were low thyroid, but the standard blood test didn't detect it. Also, significant improvement in the patients when they gave thyroid and PMS, and that's what we find. So obesity. Okay, people say, oh, I can't lose weight. My doctor says my thyroid's fine, but I have no metabolism. I can't believe it's normal. So Journal of Endocrinology Metabolism, the major endocrine journal, they looked at the accuracy of TSH in obese individuals of difficulty losing weight. They found that 36% of obese patients had severe thyroid dysfunction that wasn't detected by TSH testing. So when people say, oh, my thyroid's fine, I can't lose weight, they just tell you you got to exercise more, eat less, it's likely not true. I threw this in. There's a study here showing that if you're on a statin drug, falsely lowers the TSH, makes your thyroid look normal when it's not. And here it just shows that inflammation, so CRP, C-reactive protein, is a common. You may have had that test done. The doctor looks for it for risk of heart disease. And normal is 0.4 to about 4, depending on the lab. And you can see there, I don't know if you can see my cursor or not, but even within the normal range, the free T3 drops as you get even, again, in the normal range, a little inflammation. And that's what they find. If you find is that the more inflammation, the lower the thyroid. So you look at obesity causes a lot of inflammation, and the autoimmune disease. They're all low thyroid, but the standard tests look normal. But the active thyroid is low. Let's look at dieting. If you just do a 25-day calorie restriction, you have basically a 50% lower T4 to T3 conversion. So again, T4 is inactive, goes to active T3, 50% lower. So it drops your metabolism. But again, doctors don't check that. They usually don't. They'll look at T4 and TSH. This is an interesting study. It said a group of patients, same age, same body size, same percent body fat, and looked at their basal metabolic rate, so how many calories they burned per day. And they found that half the people actually had significantly dieted in the past. They had lost weight and was on significant calorie reduction in the past, even years previously. They found they had a 25% lower metabolism compared to people who never had a weight problem. And so that basically equates to 500, 600 calories a day. So, and that's what we see. How many people have chronically dieted? They have low metabolism. And you get the trainers who never had a weight problem go, oh, just do what I do. Well, if you do what that person does, you're going to gain weight because you likely have a 25% lower metabolism. We routinely check people's metabolic rate, their metabolism when they come in, and that's what we find. That, so what you either have to do is eat 500 or 600 calories less a day just to stay even, or, exercise for an hour and a half a day compared to someone who doesn't have a weight problem. So it shows that really, unless you fix that, success is so difficult because you really have your 500, 600 calorie a day hole just to make up. Again, diabetics, 42% reduction in T4 to T3 conversion, so 42% reduced T3 activity in the cells. Journal of Endocrine Metabolism. How come, the old joke is if you want to hide it from an endocrinologist, put it in their journal. Exercise. People say exercise more. It's shown that especially women, if they do more than moderate exercise, the body will start lowering the thyroid. So it really counteracts those positive effects of exercise because you're dropping your metabolism. So really, you got to fix the thyroid. You got to look for people who exercise. We have a lot of actually marathon runners come in. They're like, how can I be low thyroid? All I do is exercise. I just feel so much better with exercise. Because that's why you can make up some low thyroid by exercising and intensively, especially. So that's why they feel terrible unless they're exercising. So we'll talk a little about thyroid transport, and this is even this is new information for doctors even. But so again, the thyroid, in order to have an effect, has to get into the cell. And so the thyroid in the serum isn't doing anything. Now, we were taught in medical school that whatever's in the serum diffuses into the cell, goes into the cell. So check the serum level because it's going to be the same in the cell. But that's shown to be totally incorrect. Now it's known that the T4 and T3 have to be transported into the cell, and the transporters are basically energy dependent, so they need energy. Now, if there is any reduced energy, which happens with so many conditions, diabetes, dieting, chronic fatigue syndrome, fibromyalgia, that the transporters don't work very well, and especially the T4 transporter. So what happens with stress or any of these conditions, T4 doesn't get into the cell. But now the pituitary, it's totally different. Pituitary is totally different tissue than everywhere else in the body. It's the worst tissue to basically use as a marker. So what happens is the TSH looks fine or even goes down because you get increased thyroid in the pituitary, but the rest of the body's starving for thyroid because it's not getting into the cells. And this is especially true, again, for T4. So with all these conditions, the T4, which is why also T4 doesn't work for so many people because it doesn't get into the cell. So again, what happens is that actually you look at depressed patients are the perfect example. When you see a depressed patient, they're likely going to have a low TSH, a high T4, a low T3, and a high reverse T3. And if you look at studies like even, Journal of Psychiatry say, the depressed patients are a little hyperthyroid. No, it's the opposite. They're low thyroid because the T4 isn't getting in the cell, so the serum levels go up. It looks like they're high, but they're actually low because they're not where they're supposed. The thyroid isn't where it's supposed to be. So here's all these references here showing that these conditions have reduced thyroid uptake into the cell. So insulin resistance, diabetes, chronic and acute dieting, depression, bipolar depression, neurodegenerative diseases, including MS, ALS, just aging, chronic fatigue syndrome, fibromyalgia, migraines, physiologic stress, anxiety. So all those things have a low cellular level of thyroid that isn't detected by doing serum testing. Reverse T3. And a big, somewhat controversy, doctors, it's meaningless, it doesn't do anything. Well, what it does, it actually blocks the thyroid, and it blocks the uptake of thyroid into the tissue. So when you have high reverse T3, your thyroid is not getting into the cell. So in this study here, they infused reverse T3 and blocked the uptake of T3 and T4 between 23 and 34%. Interesting study here. They took blood, they took serum from stressed individuals, and they basically showed that it reduced the uptake of T4 in the cell by 44%. But in non-stressed individuals, it didn't have an effect. And in the study here, they also showed that T3 reverse T ratio was the best marker for basically the uptake and the cellular level of thyroid. And again, this is Clinical Journal of Endocrine Metabolism, the endocrine journal, but they keep denying that it's true. The study here, they had basically tested how the body responds to repeated cycles of dieting and weight loss. And what they found is after 3 cycles of significant dieting, weight loss, weight gain, that the weight loss occurred at half the rate for eating the same amount of calories, and weight gain occurred at 3 times the rate compared to the controls of the same calories. So after you had repeated cycles of dieting, weight loss, weight gain, your body will gain weight back 3 times as fast and lose weight half as fast. And a big reason for that is the cellular thyroid levels are low. So you got to fix that, or again, your dieting is likely your success is doomed. So the uptake of T4 was 25 to 50% lower in those patients. Depression. We talked about depression. They typically have a high T4, low T3, because again, the T4 isn't getting into the cell. They also are shown to have a protein that doesn't transport T4 into the brain. Okay, why do we depress patients' T4? It makes no sense. Okay, so that I wanted to give kind of a basis of, why is it that, the standard tests aren't reliable, and so basically hey, God, I got a TSH, my doctor said I'm fine. That's not true. So I'll turn it over to Mary.
All right. Thank you, Dr. Holtorf. That was a great overview of the physiology of the thyroid runaround and some of the underlying issues that are causing us to have such a difficult time. I wanted to talk just a little bit from the patient perspective. Then we're going to go back to Dr. Holtorf to talk about some of the specific tests that people want to ask for. But I wanted to talk a little bit about some of the challenges that we face as thyroid patients. First of all, one of the most critical things that we're dealing with out there is uninformed doctors, and that includes the endocrinologists. As Dr. Holtorf has pointed out, they're not even reading their own journals, and one of the issues that we're running into, which has been going on for 10 years, is this reliance on the TSH test, which we've already seen, is not necessarily something that we can truly rely on to give us a clear picture of what's going on in the thyroid. And yet, even with that test as their gold standard for the endocrinology world, they don't even agree on what the normal range is. And that's been going on for 10 years. So we have doctors that can't agree on things, a lot of doctors that are not staying up on the latest information, doctors that pick and choose which science they want to take a look at and which they want to dismiss. And we also just have a lot of doctors that are getting a couple of days on thyroid in medical school, and that's it. So your general practitioners that are dealing with a lot of the thyroid patients out there, they are not trained to really figure out what's going on. They're trained to run a TSH test and to look at whether it's marked as high or low on a lab test result, and that's pretty much the extent of their knowledge about how to diagnose an underactive thyroid. People are also running into, surprisingly enough, a refusal to test. I can't tell you how many patients I've talked with who have gone into their doctors, prepared, knowledgeable, and said, I have a family history of thyroid disease, I have these symptoms, I have these risk factors, and I think I'm having a thyroid problem and I'd like to get evaluated. And doctors will look at them and say, oh, well, I can tell you don't have a thyroid problem, you don't have a goiter. In some cases, women have just had babies. They've been told, well, if you had a thyroid problem, you wouldn't have been able to get pregnant, which is absolutely wrong because many women actually develop thyroid problems after pregnancy. And one of the most common problems that we've run into is people that go in when they are struggling to lose weight or they're overweight and they believe that they may have a thyroid condition and they go to the doctor to get tested, and doctors are saying, no, you're actually looking for an excuse for being overweight, so I'm not going to play into that and I'm not testing your thyroid. So people are actually being refused thyroid tests by HMOs, family doctors, and even endocrinologists in some cases. There's also what I refer to as the stress, depressed, and PMS syndrome. And this is a tendency for patients when they're going in and they're saying, I'm stressed, I'm exhausted, I'm tired, I'm hormonal, I'm gaining weight, I'm feeling down, I'm exhausted. And the doctors are, instead of running the complete panels of tests that are going to be able to discern hormone imbalances and thyroid issues, are instead saying, well, it sounds like you're suffering from stress, or you're depressed, or you're PMSing. And they're much more likely to hand out a prescription for Prozac or an antidepressant or anti-anxiety medication than they are to actually send a patient for a thorough evaluation of their thyroid function. And that's because it doesn't cost them any money to put you on a script for Prozac, but it costs time and money, and in many cases is going way beyond the expertise of the doctor to expect them to actually figure out how to diagnose a thyroid condition. We also have, going back to people that are struggling with weight issues, a bias against overweight people. I've talked with people who were struggling to lose weight and have been told, no, that's not why you have why you're overweight. You don't have a thyroid problem. I don't want to bother testing. I've even talked with people who were in great shape, marathon runners, who were gaining weight unexpectedly, even though they were training for marathons, running 20 miles a week, eating a very clean, low-calorie diet. And one endocrinologist told a woman she was gaining 4 or 5 pounds a week training for a marathon, and he told her she had fork-and-mouth disease instead of testing her thyroid. Well, she went to an integrative physician later who did some of the tests that Dr. Holtorf is going to talk about in the next section, and it was discovered that she did, in fact, have a very slow thyroid. Once she got treated and properly balanced, she was able to lose weight and maintain her weight loss on her healthy diet and her extremely rigorous exercise plan for training for the marathon. One last point that I wanted to bring up is the issue that, and sometimes the endocrinologists don't like me for saying this, but I oftentimes refer to endocrinology as the accountants of medicine, because the endocrinologists are very used to working with numbers. Typically, most endocrinologists spend the bulk of their time working with diabetes patients, and they're worrying about glucose levels, insulin levels, hemoglobin A1C levels. So they are looking at numbers and tests all the time to assess whether or not they're managing the diabetic properly. And this same approach is carried over now into thyroid. So there's this over-reliance and almost slavish dedication to what your numbers are, and your symptoms, or whether you feel well, or whether there's other things going wrong, seems to be taking second place to whether the numbers say you're fine. And that's kind of led a lot of patients, including myself, to have a rallying cry, we're patients, not lab values. And so while laboratory tests are important and useful and part of the picture, I know Dr. Holtorf, as well as all of the cutting-edge integrative physicians, take into account history, clinical signs and symptoms, as well as the lab work to develop a really comprehensive diagnosis and to make a good decision as far as diagnosing thyroid issues and then making a choice as to how to treat them. So I'm going to go ahead now and turn it back over to Dr. Holtorf, who's going to talk to us about the diagnosis process for hypothyroidism and how best to oversee that process and how you can really get to the information that you need.
Thanks so much, Mary. God, all that's so true. I just hear that every day, those stories. And hearing a lot more of a lot of patients will pressure their family practitioner or internist to treat their thyroid. Oh, no, I'm not comfortable. Send them to the endocrinologist. Endocrinologists will refuse to even see them because they send their labs ahead of time if their TSH is normal. It's crazy. Are they a doctor or just a lab tech? But, okay, we understand now that TSH is not reliable. Well, what do you do? So we're going to talk about what's the best test. How do you determine if someone's low thyroid? The signs and symptoms are big, and we could pretty much diagnose most people based on signs and symptoms with a questionnaire. It correlates very well with the lab tests and our other tests, the basal metabolic rate, and we'll check the speed of the relaxation phase of the ankle reflex or the brachioradialis. We'll talk more about that. And it correlates very well. Now, so a lot of times we do the test, I can guarantee they're low thyroid, but I'm still doing the test to show it to the patient, show it to anyone else who questions the diagnosis. But signs and symptoms are key. And if you know what you're looking for, you're going to find that is very, very accurate means of determining low thyroid. Personal family history. Again, we'll look at the TSH. If the TSH is high, you know your thyroid's low. No two ways about it. But the overwhelming majority of people will have a normal TSH. So, and we'll talk about different lab tests. The free T3 reverse T3 ratio seems to be probably the best indicator for cellular level of thyroid. So we'll look at a number of things there. So again, signs and symptoms. Physical exam will often pick up a lot of things. A loss of eyebrow in the lateral part of the lateral aspect. Cold hands, cold feet. If someone wears socks to bed, we call it a positive sock sign. I don't think I've ever seen a person, normal thyroid, who wears socks to bed. It's just not normal. Really sensitive to cold, depression. 90% of people with depression are low thyroid. Almost every single fibromyalgia, chronic fatigue syndrome patient's low thyroid. Again, diabetes. All the things we talked about. Look at the studies. There's about a 70% chance you're low thyroid. Basal metabolic rate. So that determines your metabolic rate, which the biggest determinant is thyroid. So we'll check everyone's metabolism. They come in, and it's nice. We show that some people are so low, they're not burning any calories, and it's like, I told you, no one believes that I'm not sitting in the closet eating bonbons, Another test is, so the British Medical Journal showed that a knowledgeable doctor looking at someone's ankle reflex was a better test than the blood test. It correlated with low thyroid better than the blood test. How could that be? Well, what happens with the reflex, the lower the thyroid, you have basically, I know you can't see what I'm doing, but the reflex goes down, but it's slow on the backswing. So there's a company that actually measures via the computer, Thyroflex, that actually gets a nice reading right there in black and white whether you have low tissue level thyroid. So all these will actually stand on their own, but we paint a picture like, look at, here's, your signs and symptoms. Here's the chance your low thyroid is very high. Now you add on the serum, free T3 reverse T ratio. You look at the basal metabolic rate and the thyroflex and relaxation phase, and it's just like every test shows you're low thyroid, and your doctor's still stuck in the old way of thinking that TSH is normal because they don't understand physiology or actually care to understand it. So in terms of laboratory, so TSH, free T4, free T3. So typically the problem is when you have chronic illness, the T4, as you talked about, goes up. So it's not a reliable marker. Free T3, a better marker, and again, that when the higher the reverse T3, typically the lower the thyroid. So it can go up in hyperthyroidism as the body tries to lower actually the thyroid level by converting to reverse T3. So in those cases, it can be higher. That's why you look at the free T3 reverse T3 ratio. Well, basically, it should be above 2 or 0.2, depends on the lab, the decimal points that they use, basically units they use. But so it should be above 2 or 2.2. And that will tell you right there. TPO, antithyroid antibody, if that's high, very, very likely low thyroid. Now, sexual binding globulin is interesting. I don't see a lot of doctors using this, but it goes up in response to two things, in response to the estrogen level in the liver and the thyroid level. So if someone has normal estrogen, and you assume that or it's not changing, which is most patients, if they're low SHBG, they're low thyroid. It's a great marker of tissue level of thyroid. So for women, it works a better test for women. If their SHBG is below 80, then they're very likely low thyroid. Now, if you're on birth control pills, it doesn't work because the estrogen basically goes into the liver and really increases sexual hormone binding globulin. But also you think about if you're on thyroid and your sexual hormone binding globulin is low, when you take oral thyroid, it first pass goes to the liver. So the liver has the highest level, and that was where sexual hormone binding globulin is made. So if your sexual hormone binding globulin is low, when you're on thyroid, the rest of the body is really low. Now, leptin. Leptin's getting a lot more interest, and there's a lot of studies going on with leptin. What is leptin? Leptin goes up when you gain weight, and it tells the body to stop storing energy. It tells the body to boost thyroid, to boost your metabolism, and lower your appetite. But the problem is that so many people that have difficulty losing weight have a leptin resistance. So leptin goes up, but the brain doesn't see it anymore. It's resistant to it, so your brain thinks your body's starving. So the brain says, store fat, lower your thyroid, lower your metabolism. And so if you have a leptin level above 12, then you're leptin resistant. And also leptin's needed to make the TSH. So if the leptin's above 12, the TSH is not reliable, okay, and you're basically, your brain's telling your body to store fat. Iron and ferritin, so iron is needed to activate the thyroid. So if that's not in that upper limit of normal, likely low thyroid activity, even though the levels may be normal. Iodine is needed to produce thyroid from the thyroid gland, but also at the cellular level. It needs to activate it. Now, too much iodine can also suppress thyroid, so you need to be careful with that. And the studies are all over the place in terms of what's the optimal level. But we'll test that on everyone. Adrenal function is important. LH, FSH. If your LH higher than your FSH, you likely have PCOS. CRP we looked at in that study, if you have any inflammation, it's going to lower your T4 to T3 conversion. Again, vitamin D, testosterone, growth hormone, I won't get into those, all interact. Serotonin. We find a lot of people with low thyroid and depression have low serotonin levels. And you can just check the serotonin level. We'll give bioidentical serotonin and get a good effect. Doesn't work for everyone, just like antidepressants, but the nice thing is that you basically, there's no side effects like the antidepressants, and it works oftentimes. And thyroid's needed to make serotonin. We'll check the bone breakdown, NTX, which tells us how much bone is being broken down, because people claim if we give thyroid and suppress the TSH that you can get osteoporosis. 20 years, 30 years of studies have shown that's not true. So, but we'll check it to prove that's not happening. Hemoglobin A1C is the average blood sugar, and so if you have a high average blood sugar, again, as we look in those studies, we know you're low thyroid, and it's contributing to that inability to lose weight and tell them in your body trying to store fat. And also with cholesterol, same thing. And here's the whole thing too. And so many doctors now they don't even think of physiology anymore. They just look. When we send the blood to the lab sends back, and 95% of people is normal. So you're only abnormal if you're the lowest or highest 2.5%. And so if you're the lowest 5%, they basically say you're normal, which is crazy. I'll get all the symptoms from that, but but they say, oh, you're so-called normal. Let's see, whoops. So I'll hand it back to Mary.
Okay. Thanks, Dr. Holtorf. What I'm going to talk about is some of the patient-oriented tactics that we can use to help our doctors take us more seriously. Certainly, if you have a doctor, an HMO doctor, or family doctor, or general practitioner who believes only in TSH testing and isn't interested in going any further and delving any deeper, then that's probably a good sign that it's time to get a different doctor. But if you have a doctor that, like many, is willing to talk with you, willing to maybe run some tests that you ask for, and is willing to work with you instead of against you, then in some cases you're going to be able to get some of these tests that Dr. Holtorf has outlined to at least get yourself started down the process of getting a proper diagnosis. But one of the ways that we need to approach this is in a very organized way, because if you just go in to a doctor and say, I don't feel good, I'm tired, I'm gaining weight, etc., it's likely that the doctor is going to perhaps perceive that these are more emotional symptoms, or that maybe it is stress or depression or something like that. Whereas if you go in a very organized and systematic way, you're much more likely to be taken seriously. So one of the things that I often recommend to patients is to go in with a detailed risks and symptoms checklist. And Dr. Holtorf has some of these. We're going to be posting some new ones up at the NAH website. There are certainly checklists at my books and websites. So we've got a lot of different resources, or you can make up your own list of risks and symptoms. But the point is to go in with a systematic list of, here are my risk factors, I have a family history, I have these 4 or 5 symptoms or these numerous symptoms, and really being clear about those symptoms with your physician. Another thing that's very important is to understand test results and to never accept normal as a diagnostic piece of information. So a lot of people, when they're early stages of trying to find out about their thyroid or get diagnosed, they go in, their doctor says, okay, I'll check your thyroid, runs the standard TSH test only, and the only thing the patient hears is they get a phone call from the nurse a couple days later that says, Dr. So-and-so called you, wanted me to call you to let you know your thyroid tests were normal. And this is the extent of the information that the patients are getting. And they'll say to me, well, they said I was normal. And I'll say, well, what tests were run? What numbers were they? What was the lab's normal range? And people don't have that information. And so one of the things I tell people as patients is that you're going to have to start knowing what tests are being run and knowing what the numbers were and knowing what range is being utilized by that lab and what your doctor considers normal. Because there was a number of studies done after the 2002 point when the endocrinology community decided they should narrow the normal range for the TSH test, which is typically 0.3. It was 0.5 to 5. They wanted to narrow it to 0.3 to 3. And it turns out that there are millions of Americans that fall into that 3 to 5 range in the TSH test, which just on TSH alone, if your TSH is over 3, it's very likely that there's something going on with your thyroid. Yet millions of people fall into this limbo where if you get a TSH test that comes back at 4.5 and you go to Dr. A down the hall, Dr. A might say, oh, yeah, you're borderline hypothyroid. I'm going to go ahead and start you on some treatment. And you can go across the hall to Dr. B, and Dr. B is going to say, your thyroid is fine. You don't have a problem with your thyroid. If you're feeling down in the dumps, it's probably depression. Here's Prozac. So we have doctors differing on what they consider normal. So you need to know what those numbers are, and you need to keep copies of your results as well, because it's oftentimes very difficult to get our hands on copies of the doctor's records. So get your test results. Ask the doctor to run you a copy when you go into an appointment. A lot of times doctors are happy to fax the results to you. If you don't have a fax machine, get an e-fax online. Those are very easy to do. You can get your information attached as a PDF. If a doctor is not electronic, do some self-addressed stamped envelopes and leave them with the nurse's office and say, please shoot a Xerox copy for me every time I get some blood work done and pop it in one of these envelopes. I found that doctor's office staff are much happier if you can hand them that stack of envelopes. That makes it a lot easier for them to do as well. But always make sure you are getting a physical copy and looking at it so that you can see if things are flagged. I just spoke with a patient the other day who said that months after month they were getting thyroid tests done, and the office was calling saying it's normal, and she finally got her hands on 2 years worth of blood work and looked at it, and her T4, free T3, they were all over the place. They were flagged as low and ultra low and almost non-existent on a number of tests, but the doctor kept telling her everything was normal because the TSH was coming out in range, and so she had no idea of what was really happening. One of the things that people run into with their doctors is that there is not enough time to really delve into some of these issues and questions. And so one of the things I recommend is utilizing the annual physical, because most of us who have an HMO or an insurance program, they allow for a lengthier office visit with a physician. So it's not the typical 5 to 7 minutes, but they may allow for 15 or 20 minutes for an annual physical. So schedule that annual physical. A lot of people don't take advantage of that as a benefit of their medical insurance or HMO services, but schedule that annual physical. Use that time to go in and ask for some of these extra tests and cover some of these issues with your physician. Another thing that I always recommend to people is to quantify your symptoms. So it's not enough to go in and say, I'm tired, I'm gaining weight, I'm sleepy. You really want to say, look, doctor, I am exercising 3.5 hours a week, and I'm gaining 2 pounds a week. Or I am sleeping 8 hours a night, and yet I still need an hour nap in the afternoon to get through the day. So if you can put numbers, put specifics, talk about calories, talk about hours worked out or hours slept, and really quantify, it becomes much more of a scientific concept to the doctors rather than going in and just saying, I'm tired, I'm exhausted, I'm gaining weight, which, again, oftentimes can be translated into more of an emotional symptom. If you're perceived to be whining or complaining about the symptoms, then you have every right to not feel well. But if you're perceived as whining, it can be perceived as more of an emotional issue, and you're more likely to get labeled as depressed than labeled as having a potential thyroid problem. And then, of course, the big issue here is finding that right practitioner, because in many cases, we can work with our GPs, we can work with our HMO doctors, we can try to get as far as we can, but a lot of times we are going to hit a brick wall with a practitioner that just simply will not think outside the box or is devoted to the TSH test, devoted to only one type of treatment, won't explore any treatment options with us, not willing to look at free T3, reverse T3, some of these other factors that Dr. Holtorf was talking about. And then, it's not always fair, but you may have to go out of your insurance network or out of your HMO and pay out of pocket to see a good integrative physician or practitioner who focuses on hormone balance. Endocrinologists focus on diseases of the thyroid and diseases of the endocrine system. So they are focused on finding these technical problems, but they are not really concerned about getting things back into balance. That's really where a more holistic and integrative approach comes in. So very often people do have to jump out of their insurance or HMO and make a few visits a year to the right kind of practitioner who's going to really spend that time and energy working with them to get their thyroid properly diagnosed and then treated. And with that, I'm going to turn it over to Dr. Holtorf again. He's going to tell us about some of the treatment issues and challenges that we face with hypothyroidism.
Great. Thanks, Mary. Yeah, and as she was saying, that some doctors, they just refuse, and this is, the TSH is fine, get out of their office, here's the antidepressant. You have some doctors that are very nice and really willing to help, but they just aren't comfortable and don't have the knowledge. And so you got to find that doctor that has both, that really cares, is open-minded, and has put the time in to learn more about the thyroid. So treatment. So, as we talked about with diagnosis, with TSH being unreliable, how to diagnose, well, how do you treat? And the problem is, one major problem is that T4 has become basically the standard treatment. But as we showed in those studies, that T4, one, doesn't convert to T3 in a lot of people unless you're totally healthy and not stressed, and it doesn't go into the cells. It's basically the transporter is deficient. So T4 is the wrong treatment to give anyone, unless they're totally healthy, they'll probably do fine. Anyone with any chronic illness, depression, inability to lose weight, stress, diabetes especially, all those things, you're giving the wrong medication. Now there's synthetic T3, which is Cytomel, and which is much better. It is shorter acting, so you typically need to give it multiple times a day. You'll get a kind of a high peak, and it will drop off. So we tend to use time-released T3. There's T4-T3 combinations, and Armour thyroid, Nature thyroid, which is a natural desiccated thyroid, which is so much better than T4. But the problem is so many doctors, they don't know how to dose it. So if you look in the books, it says that basically T3 is 4 to 5 times as potent as T4. When we do the calculations, which isn't true, they'll weigh underdose, and they'll say, if they're not used to giving Armour or a T4-T3 combination, they'll switch over, say someone's on Synthroid, give it to them, and the patient doesn't feel any better, and they'll go, see, I told you it's no better. Well, because they didn't dose it right. Because in a healthy person, almost 50% of T4 will convert to T3. So really it's 2 to 1. So they really end up underdosing the patient and use that as basically proof that natural thyroid is an old way, it's an antiquated treatment. Or with depression, it's the studies you'll see that there's claims that depressed patients are low thyroid and they give them T4, it doesn't work. Say, we'll see they weren't low thyroid. Hello, of course it's not, because you're giving the wrong treatment. Compounded thyroid drugs, and then there's a new kind of gel cap for T4. So let's see. We talked about a number of those things. Even food allergies, sensitivities often go along with the inflammation. Also, you got to watch out poor absorption of thyroid. With a lot of conditions, with irritable bowel, chronic fatigue syndrome, any of those food allergies will cause a lot of inflammation and lower the absorption. So that's sometimes the problem. Sometimes we have to give people digestive enzymes and other things to help them absorb. And it can be an issue with compounded if they use too much binder and time-releasing agent. So all compounding pharmacies aren't equal. So you want to stick with one and make sure your levels are good. So, here's just a couple of studies. Let's just look at, here was a double-blind controlled trial, 50 patients with normal thyroid function based on their TSH. Of course, we know that's not true. Randomized to receive low dose of T3, 25 micrograms of T3 or placebo in addition to antidepressant therapy. The study found almost a twofold increase in response rate with the T3 and a 4.5 times greater likelihood of experience a positive response when they're on the T3. It's like, why isn't everyone adding a little T3 to their antidepressants? The side effects were similar, except there were increased nervousness in the placebo group. Okay. The STAR report, the largest study ever done on antidepressants, over 4,000 patients. They found that 66% of patients failed to respond to antidepressants or had to stop it because of side effects. And that's what we see. Only 30% of people even tolerate antidepressants. Of those who did respond, over half will relapse within a year. So not very effective treatment. The trial found that T3 was effective even when medications, Celexa, Wellbutrin, Zoloft, Effexor were not. It was shown to be 50% more effective with less, even with smaller dose in terms of depression, 50 micrograms, when compared to the standard antidepressants. So it showed it was just a better treatment, and these are just giving thyroid to what they thought was totally normal thyroid. But again, as we looked, as we know now, no, those patients are low thyroid, and there's a reason to give them T3, but they just kind of gave it, and they found, wow, it's better than antidepressants with less side effects. Here's an interesting study. They had about 160 bipolar patients who had failed to respond to any medications, on average 14 different medications, without a response. They put them all on T3, and they found 84% had significant improvement, and 33 had a full remission. Okay, again, these are patients who tried on average 14 different medications without an effect. And they noted that one patient was switched to T4 for cost reasons and had a return of symptoms, which then resolved after they gave him T3. The authors concluded augmentation with supraphysiologic dose of T3 should be considered in cases of treatment-resistant bipolar depression. Now, they're calling it supraphysiologic because the TSH was suppressed. But because with depressed patients, the TSH is already suppressed, that's what happens. So sometimes you have to do that, and it doesn't mean you're hyperthyroid. A suppressed TSH does not mean hyperthyroidism. And the authors wanted to thank doctors who encouraged them to go above the 50 micrograms because it helped so many of their patients. So with that, so really, outline this T3 is just superior to T4, T3 combinations. Some people, T4, T3 combinations are fine, and that's all you need. Typically, the sicker the patient, the more severe the illness, the more likely straight T3 will be a better option. But for most patients, or a majority of patients, a T4, T3 is so much better than T4. And again, T4 is probably fine if someone has no stress, no weight problem, no chronic illness. Those people probably would likely do okay on T4. But as you have any of those issues, you need a T4, T3 combination or straight T3. And I'll hand it back to Mary.
Okay. I would encourage folks, if you do have questions, we're going to be taking a few questions at the end of the webinar here. So go ahead up to the, I believe it's the text chat window up at the top. It has a little bubble with like you would see on a cartoon. And if you click on there, I think you can go ahead and send messages in that way. And so we'll go ahead and take some questions in a few minutes. But I just wanted to wrap up with just some discussion of some of the challenges that we're likely to face out there. So now you've had about an hour here of sort of a crash course on everything you need to know about trying to get diagnosed for with the proper factors for hypothyroidism. And Dr. Holtorf has gone through some of the physiology. He's gone through some of the different tests and some of the issues that are underlying why we need a more comprehensive view and not just a TSH test. But you are going to find that there are some challenges because the standard of care for the endocrinology community is just this TSH test and handing out a Synthroid prescription. So a lot of patients really are going to find that it's tough to get doctors that are going to be willing to do some of these additional tests and will understand what to do with the information once those tests are done. So it's a challenge, and again, as I mentioned earlier, sometimes but we will have to occasionally jump out of our insurance or our HMO system, pay out of pocket to see physicians, particularly integrative doctors who specialize in hormone balance or endocrine issues to get really more comprehensively diagnosed and treated. We're also going to find that there is a bias against T3 and there's a bias against natural thyroid out there. Natural thyroid was used for 100 years very safely and fairly effectively by physicians until the synthetic came along and really knocked it out of the running, and it's now considered by some of the less open-minded physicians to be obsolete or old-fashioned. And in some cases, I've heard doctors say, oh, it's off the market, which is not correct. They don't even know it's made. It's porcine or pig thyroid, and they'll say it's made from beef. You can get mad cow disease. I mean, there's all sorts of misinformation about natural thyroid out there because the doctors are simply so used to being told that synthetic levothyroxine is the only drug to use. The T3 bias is very strong, I think in part because doctors simply don't know how to utilize T3. They don't know how to measure it. They don't understand what it does. And as Dr. Holtorf has pointed out, it has so many important properties in the body, but many physicians simply don't know how to test for it, how to look at it. They don't understand the role of reverse T3 in affecting the body's ability to utilize thyroid hormone. So we see a lot of doctors that are not comfortable adding Cytomel to a regimen or utilizing a T3-only therapy, or even the T3 that's naturally occurring in a natural thyroid drug makes them nervous. So when we come up against these biases, again, that's a good sign that unless you have a doctor that's really open-minded and willing to learn along with you, it may be time to jump out and find another practitioner who's going to be more knowledgeable about hormone balance. Keep in mind, though, that even with all of the options on the table, it's a trial and error process. You're going to work with your practitioner to try some different things. Sometimes the first thing you try may work, but you may need to tweak doses. You may need to add something, take something out, switch brands, etc., to find really what's going to work for you. And that obviously requires a supportive and flexible practitioner. So that's going to be one of the most important parts of this process for patients. And then I always really encourage patients to stay up to date. The National Academy of Hypothyroidism is publishing at the website many new studies and information that are being coordinated by Kent Holtorf and his various doctors. You can follow me. I am reporting on new studies and journal research and all sorts of information that's coming out of the thyroid world as well. But stay informed, stay up to date, because your doctors are probably not going to have the time to read a lot of this information. So you want to be up on the latest and know what's happening so that you can be asking the questions and advocating for yourself. Jenny, do we have any way of getting those questions in at this point?
I have lots of questions for you.
Great.
Okay.
All right. Well, I think it's probably question time.
Okay. We'll start with Elaine had a question and was wondering if Synthroid can cause bone loss or increase bone loss.
You want me? Yeah. So when I talked about, we look at the studies that any premenopausal woman, no studies ever shown increased bone loss, or if a woman's on adequate hormone replacement as she gets menopausal. Now, if you have a suppressed TSH, now this is when you purposely try to give too much thyroid, let's say for thyroid cancer or something, you can get a little bone loss, but again, that's purposely trying to give too much thyroid, and if you're giving estrogen progesterone, that shows not the case. Studies show actually antidepressants much higher risk of bone loss than giving thyroid. So, and we will monitor that, and so it's a very low risk. We'll hear that repeated over and over, you get bone loss. And we prove, we're not. People's bone density goes up. They're not breaking down bone, and the studies show it is not a concern, again, especially the premenopausal woman or any woman on hormones.
Thank you, Dr. Holtorf. Jan has a question about her lab work. Her endocrinologist will not use the reverse T3 and is very stubborn about it. She's heard that the reason may be because the test itself is unreliable, not because the theory of reverse T3 isn't any good. Is there a reliable test or lab for this? What can I say to my endo that would change his mind about ordering this test?
I mean, all the major labs do it. We do find that they're not unreliable, but typically we send the specialty lab, which is a subset of Quest. The number one, the standard Quest lab isn't quite as good. It kind of pushes everyone towards the middle, but it's certainly, it's not unreliable. I think he's just saying that, he doesn't understand how to do it. But no, we'll have certain labs with anything that we like better. Let's see, like specialty LabCorp's not bad. So, I mean, the fact that there's no evidence that it's somehow unreliable.
And the next question is from Teresa. She asks if we find that many Americans are deficient in iodine, and is 12.5 milligrams per day of iodine-iodide combination too much?
Well, I can jump in on this one. The issue of iodine deficiency in the United States is really controversial because about 50 years ago, after the introduction of iodized salt and iodine was introduced into a lot of bread products and a lot of processed foods, we really had very low iodine deficiency in the United States. But in more recent years, they've been replacing some of the iodine with bromides in breads. People are cutting salt out of their diet. They're eliminating some of the iodized salt in processed foods. And so we're starting to see a resurgence again of some iodine deficiency. And some estimates have shown that there's as many as, I think, 20 to 25% of the American population has some degree of iodine deficiency. In particular, though, we're seeing the highest levels of iodine deficiency in women of childbearing age, which is the worst group to be iodine deficient, because women who are thinking about getting pregnant, or breastfeeding have a much higher iodine requirement because of the thyroid challenges that go on during pregnancy and breastfeeding. So we've got some tests. There's the urinary iodine clearance test. There are iodine blood spot tests. We can actually get a sense of whether or not there's iodine deficiency. But the 12.5 milligram iodide combination, which is usually like an iodoral tablet, or I think it's a similar mix for various doses of the Lugol solution, that's kind of a level that's recommended by some practitioners as the recommendation for anyone with a thyroid issue. And I think that there's a lot of controversy about that, because I know some practitioners think that it's far too much and that it's likely to cause a flare in some people who are iodine replete, who have enough iodine. And then there's other practitioners that think everyone should be taking this high-dose iodine. So I don't know that it's an agreed-on issue. I think there's a lot of controversy and a lot of questions, and really what the important thing in my mind is, though, that you get your iodine levels tested before you do any supplemental iodine. And then, Dr. Holtorf, maybe you have some additional thoughts that you'd like to share about the iodine issue.
Yeah, I totally agree. That's a great answer. It is very controversial. You look at studies; they're also all over the place. What's an optimal level? When you need to be careful, especially if you have any autoimmune thyroiditis, Graves or Hashimoto's, because that can really flare it. It may be good for you in the long term, but you got to be very careful, especially in the early going. I just want to mention, Mary mentioned, women of childbearing years. If you're going to go through fertility treatments or want to get pregnant, please find someone to fix your thyroid. It could save you $30,000, $50,000, and we have so many women that go through fertility treatments, doesn't work. We fix your thyroid, and they'll get pregnant naturally. Just made me think of that. But the iodine, I totally agree with Mary. It depends on the person.
Thank you, Dr. Holtorf and Mary. Kathy has a question. She's been told by some doctors that even though when she feels better when her TSH is almost zero, the doctors have told her that there are other physiological processes dependent on the TSH besides thyroid, and they worry about it being so low. Is there any truth to this? Does it matter if your TSH is zero if you feel good, if you feel okay?
No, it doesn't matter. You look at, again, the studies. The problem is all the studies are saying, well, it suppressed TSH. A lot of those people have, the sicker the patient, the more suppressed the TSH. So, no, it's not a problem. Because the TSH, all it does is basically it stimulates the thyroid. So it's not doing anything else. There may be a little influence on bone that it has a receptor, but it's so minimal. So the answer is no. They're just uncomfortable because that's what they were taught. You shouldn't suppress the TSH, particularly because of bone loss, you'll hear. But again, the studies show that's not an issue, as we talked about.
I'll also add, too, I know a few physicians that have been in that situation, and when they're really trying to trust the patient and the symptom relief, what they've then said is, you know what, every once in a while then I want my patient to get a bone density test, and I want to just, check their heart rate, check their pulse rate, check their blood pressure, et cetera, to make sure that they're not tachycardic, that they don't have a fast heart rate, that their blood pressure is not high, and that their bone density is staying normalized. And then that gives them a comfort level, because those are really the key concerns. It's cardiac implications of being hyperthyroid, and it's bone density issues. And if the doctor can get a comfort level that there's no side effects from being suppressed, and many cancer patients, thyroid cancer patients, have to be at suppressed or near undetectable TSH levels their entire lives. So there is a body of patients who are going through that particular process with their doctor's oversight. And so many times just double-checking some of those additional factors can give the doctor a comfort level to make sure that nothing else is going on.
Oh, that's a great point. And so when you're giving thyroid, right, they're just based on the TSH. You need to look at the whole picture. You know, you don't go up on the thyroid if the heart's racing, because also sometimes it's a problem is the body becomes resistant, but the heart doesn't. So the body wants more, but the heart basically can be the most sensitive. So if your heart rate's not elevated, no, it's not an issue. And with the bone loss, we can check it from visit to visit with that NTX test that we had up there, and then you can check a bone density every 6 months to a year. But yeah, so you got to monitor like you're not giving too much. And I was assuming all those other things are fine, but the TSH by itself, if the heart rate isn't elevated, the NTX are not breaking down bone, there's not an issue with it.
Thank you very much. Okay, we have Bethany. This is kind of a question, has a couple questions to it, but I think it's a very good question. How do you treat patients with above-range Graves and Hashimoto antibodies, but primarily hypohormone labs? And do you believe in hashitoxicosis?
Yeah, so basically everyone with Graves, the difference between Graves and Hashimoto's is it's very slight, but it causes an opposite reaction. So they're antibodies against the thyroid, and so those antibodies are killing off the thyroid. So, but if one of those antibodies attaches to the thyroid-stimulating hormone receptor, now you get hyperthyroid. It's going to stimulate the thyroid. So it's causing the thyroid to be stimulated and produce thyroid, but at the same time it's killing it off. So what you want to do, sometimes they go up and down depending on which antibodies, high or low, what that ratio is. Sometimes both will flare, so you become kind of all over the place, and it becomes very frustrating. So what you want to do is, first off, is lower those antibodies. We found probably, it doesn't work for everyone, but one of the best things to try is low-dose naltrexone, which is a basic medication that blocks the opioid receptor. It's used for people, they go in the emergency room, they've overdosed on narcotics, you give it to them. But they found a very low dose, it's an immune modulator, and can really help lower those antibodies for autoimmune disease. We also use it for any other autoimmune disease, lupus, Crohn's, works great for fibromyalgia, chronic fatigue syndrome. So that's a kind of a mainstay. Selenium can also help lower those antibodies. Testosterone, DHEA are shown to as well, getting rid of food allergies. So all the things you do is the first step is lower those antibodies, and then you get it more stable. So what happens is you're stimulating the thyroid, but over time there's nothing to stimulate. So then you get low. Other things that you can do is give something to basically block the thyroid production, then give thyroid back, which you don't have to do too often, but you can, so you get a stable level, then you give thyroid to that level that you want.
Thank you, Dr. Holtorf. I have a couple of specific questions about a few of the prescriptions. Marie wants to know what an average dose of Armour thyroid is. Her doctor wrote one for 15 milligrams.
Do you want to take that, Mary?
Sure. Well, I don't know that there's an average dose. I mean, a lot of patients that I've spoken with who are on a natural thyroid drug like an Armour thyroid or a NatureThyroid are taking anywhere from 60 milligrams a day to 120 milligrams. And in the case of the natural thyroid, they refer to it by the grain. So 60 milligrams is 1 grain. So I often hear about people that are taking between 1 and 2 grains a day as a sort of a standard daily dose. Now, Jenny, the question was that she was on 15 milligrams?
Correct, so a quarter grain.
Okay, so that's a quarter grain of natural thyroid, which is really a very, very small dose. I don't know too many circumstances in which that tiny of a dose would be given. Usually those quarter grains are used to help supplement larger doses. So people are sometimes on 1 1/4 grain or 1 1/2. So a quarter grain dose is a very, very small dose for that person that's asking the question, and it may just be a starting point towards getting up to a level that's necessary, or it may just be a trial dose. In some cases, when people are just borderline. I know some physicians that will start with a very low dose of natural thyroid just as a trial for a while, just to see if there's any response at all. But I don't know, Dr. Holtorf, do you have any thoughts about that tiny a dose of natural thyroid?
I mean, it's very low, and it certainly is. We starting low and working up is great, but my sense is more times than not, the doctor's not comfortable. You give this the tiny dose and goes, and a year later, like, okay, maybe I'll bump it up a little bit. So that we usually see those types of doses. Doctors aren't comfortable with giving Armour thyroid or thyroid in general. Again, there's no harm in starting low, but being able to move up. But yeah, it's a very small dose.
Thank you. I think we have time for one more question. This is from Nancy. She is thanking both Mary and Dr. Holtorf for the great webinar. And she wants to know if you're familiar about using T3 to heal the adrenals instead of using HC. What about the use of low-dose naltrexone? Does it affect or heal the thyroid if you don't have Hashis?
Well, the adrenals and thyroid go together. They do. Now, if you're low thyroid and you give thyroid and you're low adrenal, you can possibly not tolerate the thyroid. So you have to make sure you address the adrenals. But also the adrenals need thyroid to work. So it's kind of a catch-22. So you do need to address both those areas. And again, so many issues with low adrenals. I did a review of all the studies on low adrenal in chronic fatigue syndrome and found that basically 80% of people have low adrenals, but they do the wrong test. They do what's called ACH stimulation test. And so a lot of that may be due to this immune dysfunction that they have causing low adrenals, again, at the pituitary level, hypothalamic level. So low-dose naltrexone may help even if there is no Hashimoto. So that is true.
Well, thank you, Dr. Holtorf. And Mary, I think we should probably wrap it up for the evening.
Oh, okay. I would call your attention, Jenny, if we can go to the next two slides. We've got contact information that we've included at the end of the presentation, both for the National Academy of Hypothyroidism website, and stay tuned to that website. We're going to have a lot more blog posts and a lot more of Dr. Holtorf's studies and some additional information coming in, so that site is going to be a really great source of cutting-edge information. We also have information on how to get in touch with Holtorf Medical Group, and the Holtorf Medical Group now has offices in a number of cities in California. I think we're also in Philadelphia, I believe, and then you're also looking at is it Salt Lake area for new offices?
Yeah,
so I know
soon, probably in June.
Right. So we've got some expansion going on with Holtorf Medical Group. So a lot of great doctors that practice according to the philosophies that Dr. Holtorf has outlined today and are knowledgeable about the different things that he's talked about. So there's information on how people can get in touch with them as well. And then, I invite people to touch base with me through my websites and my information. I also have a very active support community on Facebook, so people can always pop over there and share information, ask questions, join in the conversation with other thyroid patients. And then I also wanted to just point out that some of the things that Dr. Holtorf was talking about relating to weight loss and metabolic issues are certainly of interest to thyroid patients, and he was a tremendous resource in my latest book, which is The Thyroid Diet Revolution. And so he is quoted extensively. A lot of his information on leptin and some of these issues about metabolism and the basal metabolic rates is all included in The Thyroid Diet Revolution. So it's really it was a great opportunity for me to interview him and get a lot of wonderful input that I think can really help thyroid patients understand why it's so difficult for us to lose weight and to maintain that weight loss. So I wanted to just call your attention to that. So I would love to.
Real quick.
Sure, go ahead.
Yeah, her books are great, well-researched, been written so they're understandable. So I highly recommend all her books. And again, she mentioned her new one coming out. She also has a newsletter, which I'd really recommend you sign up for. Sorry.
Thank you. So I think we want to thank everybody for participating, and We had originally mentioned that we were hoping to have Gina Lee Nolan, who was a star of Baywatch and who is now a thyroid advocate, on the call, and Gina was not able to make the call. Something came up, but I hope that we're going to be able to get her on a future call with the National Academy of Hypothyroidism and with Dr. Holtorf. And so stay tuned, because there's going to be more exciting webinars, a lot of new information coming out at the website, and we really appreciate everyone joining us for today's call.
Great. Thanks so much. Thanks, Mary.
Thank you.
Thank you, everyone. Have a good evening.
Bye-bye.
Good night, all.